everybody. I see some very familiar faces out there, which is really nice. I'm really happy to be with you all today to offer this prevention of medical errors training. Now, if you're like a lot of people who go to these trainings, you're going primarily because you got to get those hours in for licensure renewal. There's always been a lot of confusion with the mental health professionals on why do we have to do preventing medical errors? We're not physicians. But we're actually going to talk about that a little bit today. My hope is, though, that you'll also find this a very practical and useful training in your everyday practice. We tried to make it that way so that it doesn't feel like one of those trainings that you just take because it's the obligatory special required CE event. So we're primarily going to be focusing today on the prevention of medical errors from a perspective of differential diagnosis, because that's one way that people can make a medical error is through diagnostic errors and therefore treatment errors that are connected to the wrong diagnosis. And I want to give a couple disclosures. I think later on in this PowerPoint, I am going to offer some resources, at least one of which, no, there are a few actually, that are from the National Board of Forensic Evaluators, or NBFE. NBFE is officially partnered with SOMCA, but also with our state chapter, Florida Mental Health Counselors Association, and is partnered and endorsed by the American Mental Health Counselors Association. But I do get an administrative paycheck from them every month as a contractor. I don't get any kind of cut or something if people like pay for a training with MBFE or they buy something from MBFE. I get no like royalties or something like that, but I do get a regular paycheck from them every month for administrative work. So you can take anything that I have to say about MBFE's products and services with a grain of salt for that reason. I'll also give you some other resources like some apps, some books, some tests and measurements. I have no financial ties or connections to any of those products or services that I'll be talking about today. And if you have questions after today, you can send me an email. I am a licensed mental health counselor and a licensed marriage and family therapist with board certifications in addictions and some forensic areas and telehealth, and I'm a qualified supervisor. And I also work at the University of South Florida in the Department of Mental Health Law and Policy as an assistant professor there. And as you know, I do administrative work for the National Board of Forensic Evaluators. And at SOMCA, I'm your legislative chair. And for FOMCA, the state level, I'm the government relations committee chair. Here's a little bit of an agenda for what we're going to cover in this training. We're going to do an introduction to malpractice and to root cause analysis. And then we're going to cover a brief exploration of some problems and barriers with differential diagnosis. With those challenging cases where you might have symptoms that are what we would call overlapping symptoms, where you might have a symptom like, for example, difficulty concentrating. And gee, what could that be attached to? Like a bunch of different disorders. That could be a symptom that is connected to many different disorders. And how do we arrive at the best diagnostic impression for that particular client's symptom presentation? And we are going to then cover 7 different tools that can help with differential diagnosis that you can use on a day-to-day basis, especially for those challenging cases where the diagnosis just doesn't seem quite as clear-cut as it does in our nice little textbook examples when we're in graduate school, right? And then we'll actually apply some tools to formulate a diagnosis for some real case scenarios that do involve real clients. Some of the facts of each case have been slightly altered to better protect the privacy and confidentiality of the clients in those vignettes, but they are based on real cases nonetheless, involving overlapping symptoms. So hopefully this looks good for you on a Friday afternoon, and hopefully this is what you came for because it's what I've got. But if there's anything else that you don't see on this slide that you were really hoping to get from today, again, just throw it in the chat box or unmute yourself at any point and ask a question or tell me, and we can see about it. I first just want to give a little background on this whole prevention of medical errors requirement for CEs in the state of Florida. Because I do often hear from people, we shouldn't have to have a training like that. We're counselors or we're social workers or marriage and family therapists or psychologists. We're not physicians. Why do we need to have Why do we need to have prevention of medical errors trainings? That doesn't make sense. And it really goes back to Florida Statute 456.013, subpart 7. And this is a statute in a chapter, chapter 456, that applies to all licensed healthcare professions in the state. And because we, as 491 board licensees, or if there were any psychologists today, 490 board licensees, because we are all licensed healthcare professionals, this law does indeed apply to us. And so that's why in our administrative code, the code that applies to 491 board licensees, we have a rule 64B4-6.009, and it says all licensees must complete a 2-hour course on prevention of medical errors, which meet the criteria of section 456.013 subpart 7 Florida statutes as part of the total hours of continuing education required for biennial renewal. That means every 2 years, we need to do these 3 hours. And if you look at the statute gets a little bit more specific about what we're supposed to cover in this training. It says that the training must include a study of root cause analysis, error reduction and prevention, and patient safety. So we somehow must include in today's training root cause analysis, how to reduce errors. In this case, we'll be focusing on diagnostic errors and preventing those diagnostic errors. And we will make the case that in doing so, we are improving patient safety. That's what we will be covering today. All right, so what is root cause analysis? It is an approach that was initially adopted in healthcare in the 1990s in the UK, US, and Australia. Now, it does not come without criticisms. There are, if you were to go to Google Scholar, and that's scholar.google.com, which is basically a Google search engine that restricts your search results to academic sources like peer-reviewed professional journals. I'm a big fan of Google Scholar, and I realize this is a tangent, but I just want to say something about that real quick. Anytime that you're thinking to yourself, gee, is a particular treatment or therapy or something, is it really effective? Um, One of the problems is if you just Google it, you'll find sources that say it's effective. You'll find sources that say it isn't. You'll find all kinds of contradictory research on things. This happens all the time. And if you have a bias, you just keep going down the list until you find the study that agrees with you. And then that's the one that you share with people to say that you're right, right? But that's not the best way to do things, is it? I suggest that you go to Google Scholar and you type keywords. You can either say meta-analysis and then whatever it is you're researching, like meta-analysis, efficacy of motivational interviewing, for example. Or if you prefer, instead of meta-analysis, you can type systematic review, efficacy of motivational interviewing. And then look at those studies only. And if you really want to get fancy, limit it to only more recent studies, like maybe within the past 7 years or something like that. Because you can do that. You can apply a filter where it only covers a certain time frame, and then start looking at those abstracts and bottom line results. Because meta-analyses and systematic reviews, unlike isolated studies, they back up and they kind of take a look at the totality of the literature, but using criteria that raises the standard of the quality of the research that we're going to include. So the more poorly designed studies are typically going to be excluded from systematic reviews and meta-analyses. And in the case of a meta-analysis, which is a form of a systematic review, you're getting a quantifiable result, which is what is the effect size of a therapy? That means, people who do this therapy, how much more, how likely are they to fare better than if they just got placebo or if they got no therapy at all? So it's a good way to do some research. But at any rate, if you were to type root cause analysis behavioral healthcare into Google Scholar, you will see that there are plenty of people who offer criticisms of root cause analysis, saying that there's not enough evidence that it's a helpful approach, even if it is a helpful approach. And you will find some researchers who say it is a helpful approach when done right and can back that up with data they provide. So I want you to know that it's not like everybody says that root cause analysis is the gold standard of all things when it comes to preventing medical errors, but it is what we are required to include in our training for prevention of medical errors. And I mean, to me, it looks like a really good approach, but you be the judge. At any rate, It was developed in the fields of systems engineering and psychology. And here's a quote that I offer from one article. It is described as a range of approaches and tools used to identify how and why an adverse event occurred in order to understand how to reduce recurrence of that type of event in the future. So if we just pause there, I'll give you an example of an adverse event. An adverse event could be a client completes suicide while receiving mental health care at a particular practice or agency or hospital or whatever the case might be. That would be an example of an adverse event in our field in mental health treatment, right? So if that were to happen, and then the practice decided to use a range of approaches and tools to identify how and why that adverse event occurred, and then sought to use that information to reduce the likelihood of recurrence in the future, then you could say we've already partially met the definition for root cause analysis, right? It's intended to be a general approach to uncovering system level causes, though. So, if you're an individual practitioner, you might think that root cause analysis doesn't really apply to you because it's really about a system. But I would say two things about that. One is, even if you're an individual practitioner, you kind of are part of a system nonetheless. That system could be the community that you work in. It could include the other healthcare providers that your client is working with. Just to give you a hypothetical example, let's say that there was an individual who presented with depressive symptoms, but in spite of getting antidepressant medication and maybe they even did some stuff like ECT or TMS, and they were doing psychotherapy and really trying their best at it all, their depression got worse. And then let's say, tragically, they completed suicide. Um, what if, what was really going on with that individual was that they had hypothyroidism? And no one caught that they had hypothyroidism, and that's what was causing the depressive symptoms. That was the sort of root cause of the depressive symptoms in that case. And somehow this got by. Well, there could be a lot of people who were involved in that oversight. The client's primary care physician, which might work in an entirely different office or practice than you. Let's say they have a psychiatrist who works at a different practice. That could be another person who wasn't screening for the potential of a biomedical condition that could better explain their depressive symptoms. And of course, you as the therapist could play a role in that kind of an error as well. The kind of error we'd really like to prevent, and that I hope this kind of training will really help you to think a lot about. So I would say you could still apply root cause analysis, even which is kind of looks at a systemic level issue, even if you're an independent practitioner. But you can also do root cause analysis where you're just looking at your own role in something too, even if that doesn't fit the definition offered in this particular publication. Because, I mean, isn't that what we ought to do anyway? If a client has a bad outcome, shouldn't we think hard about, could could I have done something better? Is there something I could have done differently? I'm not suggesting that we're at fault or to blame or fully responsible for all client outcomes, but I think it's important for us to question what role we play and to be able to, in hindsight, look back at a situation, hopefully not something quite as unpleasant or adverse as a client dying, for example, but maybe even something much more minor than that, and ask ourselves, in hindsight, is there a reasonable practice that I could have engaged in that might have reduced the likelihood of this adverse outcome? I just think it's really wise for us to do that anyway. Um, all right, so moving on, how to conduct a root cause analysis. This is actually adopted from CMS, which is the Centers for Medicare and Medicaid Services, under the U.S. Department of Health and Human Services. And in their literature, they have a 7-step process, which you could argue is kind of vague in general, but is literature on some of the specifics with these steps as well. The first is to identify the event to be investigated and to gather preliminary information. Well, that kind of makes sense. You'd have to figure out what is it that we're even interested in exploring here with this root cause analysis. What is the thing that we are looking at? Second, charter and select a team facilitator and team members. So if you work in an agency or a group practice, for example, then you would have a team and not just one person doing this. But that team would include a facilitator who's going to kind of orchestrate the whole process. The third step is to describe what happened. This would involve collecting and organizing all of the facts surrounding the event to get a clearer understanding of the event itself. Next, you try to identify the contributing factors. So let's give that hypothetical scenario again of hypothyroidism. We might go back to, okay, when clients come to our practice, do we in any way screen or assess for whether they could have a co-occurring biomedical condition? If we do, then how and when do we do that? And in this particular case, what happened? Well, it could be that you all do a great job of screening for this, and the client falsely told you that they had, met with the primary care physician and had an annual exam and got blood work done and everything was great. And if that were the case, was it documented? And if that were the case, then, well, the oversight would probably be on the client's part. Although you could potentially argue, but what if we had a practice of asking our clients if they were willing to sign a release form so that we could get some information from their primary care physician that could help us with the diagnostic process? And then the client can choose to accept or decline that offer. Well, you could argue that that even further reduces the medical error because if the client had consented and you'd gotten a copy of the record, you might have seen, wow, they haven't had an annual exam and they haven't had any blood work, and but they told me that they did. And maybe they were just wrong. Maybe they thought that what they did was blood work when it really wasn't. Maybe it was a vaccine they got instead, and they're confused about what really happened 6 months ago. I will kind of skip to the chase here. I talk about this later on, but I just might as well tell you right now that at my practice, what we do is in our intake paperwork, we ask them if they have a primary care physician, and we ask them when their most recent annual exam was and whether or not they had blood work. Now, then we've already looked at that information before they come in. So during the initial intake, I'll look at that, and then my questions might be guided in part by what they wrote, because they might say, I don't have a physician, haven't had an annual exam. And then I might recommend to them in the first appointment that they get an annual exam, report the same symptoms they've reported to me to their physician, and then find out what kind of blood work or other diagnostics the physician may want to do just to rule out any potential biomedical causes or contributors to their symptoms. Now, then the client either accepts or declines that offer, and then I document their response. If I found that they did have an annual exam, then during the interview, I asked them, when you had that exam, did you report to your physician the same kinds of symptoms that you're reporting to me? Because what's interesting is I didn't used to ask that question earlier on in my career. And I started asking it because I discovered that there are clients who, yes, they see their physician and they get their annual exam and they don't tell their physician anything about depression. And they even lie when they answer questions about mental health screening. So I'm taking it one
Absolutely.
step further and I'm asking them, and have you talked to your physician about these symptoms? And you'd be surprised how often they tell me, no, I haven't. I haven't talked to them about it. And there are a lot of reasons they don't. Sometimes it's embarrassment. Sometimes it's I'm in a rush and I don't want this thing to take on, or I don't want the physician to think I have a problem, or I'm already seeing a therapist and I don't want to hear their lecture about I should go see a therapist. Or there could be 100 reasons why they don't. And it's normal for clients to not be fully accurate and or honest in their self-report when being evaluated by healthcare professionals. That's actually not abnormal. That happens an awful lot in the professional literature. Another good thing to plug into Google Scholar is a research on clients and whether or not they lie to their therapist or give inaccurate information, and how often that happens in surveys of psychotherapy clients. So it's important sometimes to take it an extra step. And what I'll often do actually is if they haven't had an exam, or they had an annual exam but didn't have blood work, or they didn't report to their physician the kinds of symptoms they're reporting to me, then I offer for them to sign a release form for me to send a referral letter to their physician, where I just say, hey, I've referred our client in common to you for an evaluation because they reported these symptoms, and I list the symptoms, and I'd like for them to rule out any potential biomedical causes or contributors to those symptoms. Now, you could then say, Aaron, that's extra work, and I feel like that's overkill, and I don't want to do all that. And I think you can make a case for that, but I don't think it, if you have a good template, a form letter, or you have some support staff, it's really the kind of thing that only takes a few minutes to do. It's not very time consuming to do those things. And you're only doing it once up front with a client. I think it's well worth it. And I would love to encourage you to consider being more integrative in your approach to treating clients. One thing that's certainly concerned me, and I know there are counter arguments to this. It's okay to have different opinions, but it concerns me that so many clients have a variety of healthcare professionals working with them, and many of them don't know what the others know about the client that could give a more cohesive picture. That's part of why, a client struggling with alcoholism gets benzodiazepines from one physician who doesn't know about their alcoholism when someone else they're working with knows about it, or somebody with a family history of psychotic disorders gets recommended for medical cannabis, which is a terrible idea for somebody that has that potential predisposing variable in the professional literature. But the physician who spent 5 minutes with them before recommending medical cannabis doesn't know that their family has a history of psychotic disorders and that they could be triggering a lifelong condition for this client by giving them THC from cannabis. So often it's a fractured system where one party doesn't know what the other party knows, and so clients don't get the best care because of that. I'll get off though the I feel like I'm preaching at this point. So so I will stop. We'll come back to this issue again later on anyway, and I'm certainly not trying to make anybody feel insecure about their current approach, but these are some ideas to consider. At any rate, we would then also identify the ultimately what is the root cause of the adverse event. What is the root cause? And that's tricky. That can be very challenging to determine sometimes. And then design and implement changes to eliminate the root causes. So if you added a question or two to your intake packet um, to screen for medical conditions in that hypothyroidism example, then that would be an example of a change that you're implementing to eliminate root causes. Or that you change the questions you ask them during their initial interview. Or you offer to every single client a release form being signed to their primary care physician if they have one, and explain why and how it could potentially benefit from them. And then they have the choice of opting in or out. Because you can't make clients do things, right? You can influence them with information and relationship, but they could still decline some of the things that you're recommending as a part of a thorough evaluation or assessment process. But at least the error is not on your part then when they do that, especially if you documented it. And then finally, you measure the success of changes. Do these steps seem to be improving things? And how do we measure that exactly? How do we know whether these steps are helping or not? And it looks simple, these 7 steps on a screen, but it can actually be really hard in any particular specific example to go through these 7 steps sometimes. And other times it's pretty easy. It all depends on the situation and who's on your team, right? So now let's shift our focus from root cause analysis towards malpractice. Here I'm quoting from a textbook that I like to use, written by Remley and Herlihy. The definition offered for malpractice is professional misconduct or unreasonable lack of skill. And it's been defined as the failure to render professional services to the level expected in a particular community by a prudent member of the profession, with the result that a recipient of services is harmed. That's an awful lot to break down, so I prefer to focus on the elements of malpractice. Before we do that, though, I should say that malpractice can be you intentionally did something that you knew was wrong. It could be, no, you didn't. You're just incompetent to do something that you thought you were competent to do, or maybe you didn't think you were competent to do it and you did it anyway. And it can be unintentional wrongdoing. It can be, oops, I didn't even know what hypothyroidism is, and it never occurred to me to ask them about blood levels or TSH levels. I don't even know what that stuff is. It can be unintentional as well. But what are the elements of malpractice? Okay, let me pause here and say that if an adverse event happens, even a terrible adverse event like a client's death, that doesn't mean that you're at fault. It doesn't mean that you're responsible for it. It doesn't mean that you did anything wrong either. Uh, I can remember the first time, it's fortunately only happened a few times in the course of my career. And for many people, it's happened 0 times, but I used to work in a setting with very high risk clients. Specifically, I worked on the campus of a hospital that had a psychiatric unit. And so clients often either with very persistent and severe mental illness or who were maybe chronically suicidal might get hospitalized. And then upon discharge, they would see me for an assessment to determine the appropriate level of outpatient care. And for some of them, then I would provide that care. And for others, they would be assigned to other caseloads in our office or referred out to a different office based on the kinds of services that they needed. But at any rate, it was a fairly high risk population. And I can remember having a client who had been hospitalized for a suicide attempt. And he was discharged. I did my assessment with him. And I remember sitting there in the assessment thinking, he's just oozing depression into the room. It's like he's bleeding just a depressed mood from his affect, and everything about him just looks and sounds like depression to me. And he was denying every symptom of depression. Um, and I actually, to my, later on when I was looking back at this case and reflecting on it, kind of doing my own root cause analysis, um, I saw that I'd actually written that in the intake note, that although client presents appearing depressed to me as evidenced by, and then I described it, he is fully denying all symptoms of a depressive disorder. Um, and what I didn't know at the time was that that client he determined I tried to kill myself. Somebody caught me and got me medical care before I could die. So what I'm going to do is I'm going to play my cards this time and I'm going to set myself up to be able to kill myself. And part of that was he was going to comply with every recommendation. He was going to get all his ducks in a row so that he could be successful with suicide this time. So when he killed himself, which happened after appointment number 2 with him, and unfortunately, his son found him hanging, and he had taken measures in between appointments to sort some final affairs that he wanted to attend to, written a letter, and then he hanged himself. And he made it clear that the reason why he wouldn't tell anybody about what he was really experiencing was because he knew they would try to stop him. Now, as horrific as that can be, as sad as it can be for a client to kill themselves, it doesn't mean that you did something wrong as a mental health professional. When I looked back at the case, I was thinking, where did I go wrong on this? That was my first thought because my kind of default assumption every time that something ends up kind of bad that I'm involved with work, it's almost like it's like an automatic thought. Gee, how did I screw this one up? It just happens like that. That's sort of my initial filter. And then, through the miracles of cognitive behavioral therapy, I've certainly learned over years to notice that initial thought, nod at it, thank it for trying to do its best to help me to be a good performer in life, and then remind myself that it gets a little carried away, and that I have a overly strong internal critic, and then start to introduce reason after that point. And so then I looked back at the case and I was reading the intake note and I was like, I'm going to try my best to find a place where I went wrong. And I couldn't find one. And I, had the psychiatrist who was also working with him and that outpatient clinic went back and looked at the file and couldn't find anything that we could have done differently. Um, it's not for lack of risk assessment. It's not for lack of questions. I even told him that he presents to me as somebody who's depressed, but is denying depressive symptoms, and that I'm a little confused given that he was recently hospitalized for a suicide attempt. And I actually said something on the lines of, I do hope that if there are things that you're not telling me about, that as you get to know me and we build a therapeutic relationship, that you might feel comfortable sharing some things that you're not quite comfortable sharing right now. Which was interesting because I remember a look on his face when I said that in the session. But he still didn't tell me anything. But so when I look back at it, I cannot find a thing I could have done differently. So I'm certainly not suggesting to you all that if you have an adverse event, that it means that you have done something wrong. I'm not even suggesting to you that if you made a mistake, that that means that you've engaged in malpractice, because here are the elements of malpractice. Number one, you have to have a duty to the person for whom it is being alleged that you performed malpractice. Now, what that means is, let's say, okay, I'll give an example. I was at a kung fu lesson early this morning, and a buddy I have there was telling me about some marital problems that he's experiencing. And I offered a suggestion to him, which was to, have you all ever considered doing any marital therapy, basically? Now, let's say that hypothetically he then got into marital therapy, something bad happened, and then let's say that he wanted to allege that I gave him bad advice and therefore I've performed malpractice. I certainly have not, because I didn't have a duty to him. Because what we mean by duty here is that you are their provider. A friend who seeks out a little casual advice is not a client or a patient, right? We didn't enter into a client therapist relationship. I in no way inferred that we were in such a relationship in any way. I don't have a duty to them in that context, right? So you have to have a duty. They have to be your client or patient. Now, you could argue, though, that maybe like if you were a trainer or a consultant and somebody became a client that you were providing training or consultation with, and you gave them really bad information, and then because of that, an adverse event occurred, you could potentially be sued. Um, and that's part of why in your malpractice insurance policies, if you do any kind of training, supervision, you're a qualified supervisor, or consulting, you must add extra coverage for that. A lot of supervisors don't know that. They think that your standard malpractice policy will get the job done, but it does not cover training, consultation, supervision. It covers psychotherapy, essentially. And so it's super cheap. CPH actually gives it to you for free, but you have to ask for it. And if I remember right, anyway, so don't fully quote me on that, but I think it was free with CPH. HPSO charges you a very small fee to add it. I feel like it's $20 a year or something like that. So worth its weight in gold. Please make sure you do that if you're doing training, consultation, or supervision. But anyway, second element of malpractice is a breach of duty. So you have failed to conform to your required duty of care. Now, what's a breach of duty? It's not just a mistake. Everybody makes mistakes, right? We all make mistakes. No one is errorless. It's not just a mistake, but it's a mistake that is clearly contradicted by the standards of your profession. Like there's a big difference between, oops, I accidentally double booked my hour this hour, and now I've got two clients sitting in the waiting room. That's a mistake, right? Is that some kind of substantial breach of professional standard in our practice or something like that? Is it a clear oversight? You should have known better, done better. I guess if it were happening a lot, but probably not an isolated event like that would not be framed as a breach of duty. Oops, I slept with my client. That's a breach of duty, right? No question about it. Like every standard in our field says, don't do it, period, end of story. Laws, rules, and ethics, and it just bleeds breach of duty, right? Um, so there are minor mistakes that aren't a substantial violation of a professional standard, and then there are mistakes that are a violation of our professional standards. I'm going to argue today to you that a more holistic assessment is our standard of care, and that failing to provide a holistic assessment, um, and then that leading to or approximately causing an adverse event could be a successful malpractice claim. But we'll come back to that. Third, because of your mistake that runs contrary to professional standards, an injury was caused to the client. The client has suffered injury. There's been some kind of significant suffering. Sometimes you make a mistake, and it's not like anything terrible happened from it. You double booked two clients for the same slot. You apologized for the oversight, rescheduled the second one to a slot the next day. And the worst harm was Somebody spent 15 minutes driving to your office that they didn't have to spend. That's not, injury to the client, substantial injury, right? But your client's suffering for 4 years as their depression gets worse because no one screened for a biomedical condition that could be better explaining their depressive symptoms. Well, that's probably injury to the client. Maybe they lost a job along the way. Maybe they got Baker acted for suicidality somewhere along the way. Maybe there's been a loss of productivity because of that depression, a loss of a relationship, all kinds of other possibilities. Who knows? And then next, there has to be a proximate cause. That means that there's a reasonably close causal connection between your breach and the injury. So I have a duty to this person. I breached that duty, and because of that breach of duty, I my client has suffered loss, damage, or harm. That's really what malpractice is. You have to have all of those elements. I have a duty to this person. I messed that duty up somehow. And because of that, they are harmed. That's a simplistic way of thinking. Okay. And, it's not clear cut always, obviously, whether somebody's engaged in a malpractice. Now, in Florida, we have a statute. I like to call it the You Should Have Known Better statute. And it's 491.009, subpart 1, subpart R. The following acts constitute grounds for denial of a license or disciplinary action. And then it gives you a whole bunch of examples. And one of those is failing to meet the minimum standards of performance in professional activities when measured against generally prevailing peer performance, including the undertaking of activities for which the licensee, registered intern, or stakeholder is not qualified by training or experience. So, what this basically means is if we looked at what it's a commonly accepted standard in our field, whether it's codes of ethics, or it's standard clinical approaches, we failed to uphold those standards. Now, I'm going to give you an example of this. In Florida, in Chapter 491, let's just say, there's not a statute that explicitly says that you cannot write an emotional support animal letter for a client without conducting a thorough disability related evaluation first. There's not a statute that explicitly states that. And yet, at least 4 licensees that I know of have been disciplined by our board for exactly that. How did they discipline them? They used this statute that you see on the screen, which is very frequently used for disciplinary actions with the licensure board. Because it covers everything that you should have known better about, pretty much. And that would include, I think, substantial diagnostic errors could be included in this. It could include a dual relationship that caused harm. Now, there actually are some, at any rate, even though the statutes don't say you can be disciplined for failing to abide by the American Mental Health Counselors Association Code of Ethics, it does say that you can be disciplined for not meeting the minimum standards of performance in professional activities measured against generally prevailing peer performance. And that includes our codes of ethics. So it's an important statute to be aware of. Now, so far, you might be thinking, gee, man, this is a depressing Friday training. I wasn't expecting this. I just wanted to get my medical errors hours. And geez, this guy is bumming us out with malpractice and discipline and suicide scenarios. What is wrong with this guy? But we will get brighter and we will get into stuff that's really more about how do we even do a better job than we're already doing and how do we help our clients even more than we're already helping them. But first, some more of the bad news. This is from that same textbook, Legal, Ethical, and Professional Standards in Counseling, about state licensure board complaints. Some stats: 24% of them involve inappropriate dual relationships. 17% of them involve some kind of incompetence. Now, that could include diagnostic errors. That's an example of incompetence, right? 8% practicing without a license or misrepresenting their qualifications. People call themselves doctor when they are really all but dissertation people who don't have their doctorate yet are an example of what might fit into this category. Or they're calling themselves doctor in their professional work when their doctorate has nothing to do with mental health. Could be another example. 7% having a sexual relationship with a client. 5% breaching confidentiality, 4% inappropriate fee assessments, 1% failure to obtain informed consent, and 1% for failure to report abuse. Now, I will tell you, the vast majority of egregious mistakes that mental health professionals make never end up in front of the state licensure board. I mean, how many of you in the course of your careers have heard some horrific stories from clients about inappropriate things that therapists did in the past that were never reported to the board? I mean, it happens a lot more than is ever reported for a lot of reasons. Sometimes the people involved don't want to go on the record or report something to a licensure board, or they don't even know how to do it or that it's an option. Or they don't even know that what the mental health provider did was technically wrong. There are all kinds of reasons why people don't want to report things to the board. Now, we could take a step back and say that even the medical model itself and diagnosing mental disorders is a double-edged sword. Some of you are not excited about the medical model. You're like, I don't even like doing this medical errors training because I hate us thinking from a lens of as though, everybody's in a hospital when they come to therapy. That's the way it feels to you. And you're like, we are way too focused on pathology and symptoms and disorders, and we should be more wellness oriented, like counselors tend to be actually by professional identity. Um, and I guess my counter to that would be we can't have our cake and eat it too, because we wanted to have a license, right? Who needs to have a license? A healthcare provider. Um, we wanted to have the right to diagnose and treat mental disorders and provide psychotherapy, which is counseling aimed at alleviating significant emotional distress or at treating conditions. So if we want a license and we want power, then we have to have responsibility too. And so you could be an existential or Rogerian or a postmodern or a feminist therapist, let's say, who's like, "Ah, we spend way too much time on pathology and diagnoses and symptoms." And in the room with clients, you could use an approach that feels much less clinical in nature with them, but you still better be doing this stuff if you're a licensed healthcare professional. Even if most of it's just what you see in your records and it doesn't feel, I don't think my clients feel like they're walking into a clinic when they come to see me by any means. I don't think that's the style and approach that I have in counseling, but you can believe that I'm doing comprehensive assessments and I'm very much assessing symptoms and diagnosing and ruling out different possibilities and creating treatment plans and great progress notes, which all of which we are required to do by law, by the way. I've had this debate with people where, like, I had an intern who worked for an agency and they did not, and she said, the problem with treatment plans is we don't have a template for it in our EHR. And I'm like, what? How can you not have a template for a treatment plan? And she said, they just don't have one. And I'm like, you have to have a treatment plan on file for every client. That is mandatory. You must. And she went to her administrator who said, no, we don't have to have a treatment plan on file for clients. And they pointed to a statute in Chapter 491 that says that you must have a treatment plan record, but it doesn't specifically say that you must have a treatment plan. That's correct. The statute doesn't specifically say you have to have a treatment plan. However, the statute does say that the board may adopt rules further defining records and regulating their maintenance, storage, and release. You then go to the Florida Administrative Code, and there you see it in black and white. You must have a treatment plan on file. You also have to have a list of financial transactions between you and the client. You have to have progress notes. You have to have what their progress is in therapy, diagnoses if applicable, certain demographic information, consent forms, release forms, etc. They're all listed there in the Florida Administrative Code. So they are codified. And if you do not have those, you are violating the statute as well as the rule. And in fact, I want to show you a little secret here. Well, I guess it's not a secret, but it kind of is because most people don't know about it. We're going to go to, and I think you'll still be able to see my screen when I do this. I'm going to drag a browser over here, and we are going to go to Florida's mentalhealthprofessions.gov. That's the 491 board website, right? And we are now going to click on meetings. And when we go to meetings, we see right here that there's the future, the next meeting on February 6th, and then there are past meetings. Let's click on past meetings. And when we do that, we can see all the past 491 board meetings. Let's go to November 18th. Here are the full minutes. Click on that, and you can see the record of the disciplinary cases. Let's go to August. There you'll see disciplinary stuff. Yeah, disciplinary proceedings. Okay. So you can look at the name of any licensed mental health professional who was disciplined, and you can look up the case number. And if you do that, then you can go back to here's verify or look up and verify a license. You can click disciplinary and admin actions. You could also go to the license verification and get there that way too. There's more than one way to get there. We'll do the 491 board, and we're going to put in a case number. Notice it says please exclude hyphens, and then click search. And then you can click on the case number and you can get the details. The administrative complaint, what exactly was this person alleged to have done? And then what was the outcome of their disciplinary action? You'll also see the statute that they violated. This was actually an unfortunate case. I kind of feel bad for this individual, so I kind of want to not spend time on that one. But that was actually a case where, if I recall correctly, somebody had brought a new therapist into their group practice, and they took the therapist said they have a license and they didn't verify it online. And then lo and behold, the person didn't really have a license. And as far as I can tell, they seem to be a conscientious, individual who just didn't think that they would have to double check what somebody's told them. So that was a lesson learned for a lot of people. If you're in a practice, don't bring anybody new on without looking up their license and verifying it, which you can do right here on the board website, by the way. Make sure that their license is still active. But if you do this, you will see that the majority of disciplinary cases, people get pegged for not having appropriate records. Why is that? It's not because clients are reaching out to DOH, Department of Health, saying, my therapist doesn't keep good records, because usually the client doesn't even see your records. I mean, they have a right to access it and under certain conditions, by the way. But usually what happens is it was alleged that you did something else. You charged them incorrectly. You claimed that they saw you on a date that they never saw you, so you could get money from an insurance company, or it's being alleged that you did something inappropriate with them, some kind of boundary crossing, or whatever the case might be. That's the complaint. But one of the first things that the DOH investigator does, if there's reason to believe that this case should be investigated, is they get a copy of the record from you. They look through it, and if it's missing the components that the rule says you must have, then they're going to peg you for that, in addition to whatever else that may have related to the complaint for which there is good evidence that you have violated, a statute or rule. So that's why you see so many records violations at these 491 board meetings. So believe me, you do have to have treatment plans. Let's just get that out of the way. And it's concerning to me when I hear from people, oh, I don't keep progress notes, or I don't, because my clients aren't insurance clients, or I don't keep treatment plans because the law doesn't say I have to. Yes, it does. Anyway, I digress a lot. I go on tangents. So let's get back to this. Benefits and drawbacks of diagnosis. Here are some benefits of diagnosing clients. It's part of our scope of practice, and to be licensed, if we're going to be licensed, we have to be people who can diagnose, right? And we can get paid by third-party payers because that insurance companies don't pay people who can't diagnose and treat things, right? So if you want to have your cake, then you gotta diagnose, right? Assist with case conceptualizing and treatment plan. It creates a structured way of making sense of information. It creates a schema to operate from. Like most of us, we know that if a client has major depressive disorder, well, we know that that means they've had at least one major depressive episode, and we already know what some of the common treatment approaches are for depressive disorders, right? And in a second, we can think of a lot of things just because we heard one phrase. It makes it so much easier and organized to do our work. And it allows us to get a sense of prognosis when, diagnoses have different prognoses. For example, we know that people don't have schizophrenia and then just magically don't have it 3 years later. We know this is probably going to be a chronic and persistent disorder that they will have to manage, and that we're not going to use a let's cure you of schizophrenia model. Um, that's an example of a benefit of labels and diagnoses, right? It facilitates communication between professionals. Because if I reached out to somebody and I said, okay, yes, this client feels sad, down, and depressed the majority of the day, nearly every day, with difficulty concentrating. They experience excessive daytime fatigue. They have a difficult time falling asleep at night and staying asleep. They have had a reduced appetite and they've been gaining weight without attempting to. And they experience reduced interest or enjoyment or pleasure in activities they normally would enjoy. That's a lot of words, right? Versus me saying, this is a client diagnosed with major depressive disorder. And maybe that's all you needed to hear for whatever it is that I'm trying to convey to you in this moment anyway. So it makes it so much easier. And it creates an international language too, because that's why we have ICD-10 codes attached to every disorder in the DSM, because that's from the International Classification of Diseases. And someone in Italy who's writing in Italian is using that same number for the same thing that we're using. So we can now do international research and we can compare prevalence rates around the world. And if somebody's researching a really cool treatment for depression in Italy, then we're going to be able to track it as being something that makes sense to us in the US or in Australia or wherever else too, right? And it helps us to identify conditions that may require a referral to a physician too, more easily. It gives us a framework to conduct research. And it can be comforting to clients. Many clients, when there's a name for the thing, then it already loses some of its power because that means there's hope. Oh, this is a thing. You know what it is. I remember the first time I had a client who experiences sleep paralysis, but they didn't know that sleep paralysis was a thing and that there's research about it. And so when they were describing it, and they're like, I know this is going to sound super weird, but here's what's going on, and I don't know what it is. And I'm like, oh yeah, that sounds like sleep paralysis. Here's what sleep paralysis is, and here's what percentage of the population has it. Here's what's believed to be going on in the brain when sleep paralysis happens, and here are some interventions we can use for it. That's very relieving to clients to know that all this framework exists, that this is a thing, a real thing now, and that there's information about it and approaches for it. So it can be good in those ways, but it comes with risks. It can trigger shame and embarrassment with people. It can lead to stigmatization. It can create a self-fulfilling prophecy. A client takes on the label and they wear it as though an identity and actually get worse. They maybe learn new symptoms of the disorder that they didn't have before and they start to experience them, which maybe even happens subconsciously. We're going to talk about that phenomenon in a little bit here. It can affect employability in sensitive occupations. Somebody's trying to get a high level federal government clearance, maybe, but they have a diagnosis of schizophrenia. Could that affect the likelihood or create barriers to them getting that high level of clearance? Child custody cases, a parent's alleging, well, this parent, because of their depression, they're unfit to parent and they shouldn't have custody privileges with our child. Well, there might be validity to that, or it could just be demonizing somebody who has a mental health condition that they are working very hard to get relief from, and that they're actually a very responsible, loving, and fit parent. So there are drawbacks and benefits to diagnosis. But having said that, just a little bit of information about our code of ethics and what it says about testing and assessment. And by the way, I forgot to tell you all this, but in about 23 minutes, we'll take a 10-minute break just to let you stretch, get a refreshment or whatever halfway through. But for assessment, we are ethically obligated to choose appropriate assessment methods that are reliable and valid. We can justify why we're using this measure or this assessment approach with this particular client, why it makes sense for them. And we should avoid using outdated and obsolete measures and provide an appropriate testing environment if we're going to do testing of any kind. When necessary, we use multiple sources of data. A client self-report is one source of data. So remember the hypothyroidism example I gave you earlier. A client says, yeah, I see a physician and I feel like I probably told them stuff about my depression. And I think they did blood work. I remember them taking, some kind of jab at me. So I think that was blood work. And I assumed that it was all good because I never heard anything back from them. Well, if you got a second source of data, the records from the primary care physician, you may find a whole lot of stuff that the client was wrong about in their self-report. Maybe they're a poor historian. Maybe they have a traumatic brain injury or some neurocognitive limitations or some intellectual limitations, or maybe they're just so stressed in their life right now that they're not tracking things very well like they would, or they're so depressed that they're not tracking things as well. So multiple sources of data can include not only the interview with the client, but it can include tests and measures. It can include sometimes talking to other people who can give you good information, like a family member with appropriate informed consent and all of those other great things. And it could also sometimes involve a collateral interview. Like maybe I know it's rare for us to have this opportunity, but sometimes it happens. Maybe you could spend a few minutes talking to their psychiatrist who might be able to answer a question that has been raised in your mind about the work they've been doing with the client or something along those lines. Those are multiple sources of data. And we must consider multicultural factors because what is normal and healthy in one cultural context may not be in another. And a client might be presenting with poor eye contact, and you're thinking that could be a sign of depression, but that could be a sign of respect in the culture they came from instead. So, we should also only use those different measures and approaches that we're competent to use, evidenced by our own training, education, and supervised experience. You see some very similar information in the ACA Code of Ethics that we will not go into too much here for time purposes. Now let's define differential diagnosis, because that's a big part of what this workshop's about, right? The process of choosing which diagnosis to make when coexisting diagnoses, such as addiction and another mental disorder, occur simultaneously. There are other definitions of differential diagnosis. Another alternate definition is it's just the process of differentiating whether an overlapping symptom is better explained by disorder A or disorder B. I think that's a good way to think of differential diagnosis. A symptom like difficulty concentrating, which could be present in a wide number of disorders, or could not be a disorder at all, for that matter, because we all have a hard time concentrating and focusing sometimes. So differential diagnosis is that process of trying to differentiate whether these symptoms or syndromes or experiences are better explained by A, B, or C. So here is a polling question. I think maybe for time purposes, I'll just ask you verbally, and you can either say it out loud or you can put it into the chat box. But what do you think are some barriers to differential diagnosis? What makes it hard for us to truly do this in our clinical practice to differentiate whether this symptom could be caused by this, or this other thing over here? Any guesses? In the
Similar
chat box, we
symptoms.
have it's time consuming. I'm so glad that you said that because if we're to be honest, that's one of the biggest barriers. I mean, I'm not saying they don't do a good job with what they have, but most of my clients who see a psychiatrist through insurance say they spend 15 minutes or less in the initial appointment with that psychiatrist. How how much of an intensive process can you do with differential diagnosis in 15 minutes? I know sometimes they do it well, sometimes with a small amount of time. They do a good job with a little bit of time they have, but it's a substantial limitation in the field. Cultural limitations are another barrier in the chat box here. And so many different variations and overlap. Sometimes, where do you even start? A client has so many complaints and concerns. You're like, gee, I feel like there are 50 possible diagnoses right now. Where do I even start with this? There's so much going on here, so much overlap between their symptoms and different conditions. What could be going on? Anybody prefer to unmute themselves and answer or give their thoughts about that question? All
I
right, we'll
think a
move
lack
on
of
before
specialized
I.
training,
Oh, Rayma, go ahead. Sorry.
a lack of specialized training. So, for
Yes.
example, if you don't have training in eating and feeding disorders, or you don't have training in trauma, it could be hard to diagnose.
Absolutely. We think so. A couple things can happen. We realize that we're kind of incompetent in an area and we're just doing the best we can with our low level of expertise and providing a tentative diagnosis. That's a barrier to differential diagnosis. Also, we don't know that we don't know. That's, I think, a very common problem. We don't know that remission from an alcohol use disorder is not defined by whether they're still drinking alcohol. It's defined by whether they're experiencing any of those 11 symptoms of a substance use disorder within the past 3 months, and, with the possible exception of a craving. But we thought that it was based on whether they're drinking still or not. And that was what defines whether somebody's in remission or not, because we didn't know what we didn't know. We thought we knew it and we were wrong. That happens absolutely as well. And that's a form of lacking competency or expertise or specialization in an area. I did an ADHD evaluation recently because the therapist working with the client thought that the client had ADHD, truly thought the client needed some accommodations at school for it, but they also recognize that they really lack some expertise in evaluating and diagnosing that condition, so they referred them for a more intensive evaluation. That's great. It's great because the therapist recognizes I'm not an expert in that area and I don't really feel confident or comfortable in evaluating and diagnosing it for it, but I do see some warning signs. I know I'm going to refer them to a specialist. That's wonderful. But how many times do people diagnose people with ADHD because they think they know how to diagnose it, but they don't? Because they did an ADHD self-report scale where the client says yes to every symptom of ADHD. So they say clearly ADHD. I mean, these are the diagnostic criteria. They said yes to it all, ADHD. But they didn't rule out whether it could be an anxiety disorder that causes those symptoms instead. Whether maybe every time the client has difficulty concentrating and focusing, they're feeling anxious. But when they're not feeling anxious, they have no problem with concentrating and focusing. That's not ADHD in that case, even though they'll endorse every symptom of ADHD, maybe that's not ADHD because ADHD the cause is executive functioning problems, not anxiety. So anyway, we'll get to maybe a case about that later on. So there are lots of barriers, right? As many as 45% of patients satisfy criteria for more than one disorder in the course of a year. And this is in the world of psychiatry, this particular study. So that's like, roughly half of psychiatric clients are going to have more than one disorder in the same year. And then take the difficulty concentrating. That could be caused by lots of things. It could be depressive disorders. Literally, that's one of the symptoms of a depressive disorder. It could be caused by bipolar disorder because maybe they meet all the criteria for a depressive episode. Oh, but you forgot to figure out whether they've had a history of hypomania or mania, and therefore bipolar is a better diagnosis. And actually, some antidepressants could actually exacerbate their symptoms because they have bipolar that would otherwise be great if they had unipolar depression. Oopsies. That's a common example of a mistake, right? Anxiety disorders like generalized anxiety disorder, difficulty concentrating is a symptom of generalized anxiety disorder. It's right there in the DSM, but it's difficulty concentrating because of anxiety, not because of executive functioning problems like you see in ADHD. It could be neurocognitive disorders like ADHD, though, where you were told it's there's also at the kung fu place that I go to, there is a teenager who is like your classic case of ADHD. And it was amazing seeing him try to test for 4 hours in a row for his next level because even when he's like doing the movements, he's like, what's that over there? And he's looking at this other thing. And even if he's not nervous and he's having a great time, you just cannot get him to focus on something for more than 5 seconds. And it's not anxiety. But trauma and stressor related disorders can also create difficulty concentrating. So can sleep-wake disorders because it's the inadequate sleep that's creating the difficulty with daytime concentration. Or what if they're withdrawing from nicotine and that's when they have difficulty concentrating? Or they're currently under the influence of a psychostimulant when they don't have ADHD or some other kind of neurocognitive disorder, and that's creating the difficulty concentrating. Or maybe that's what's enhancing their difficulty concentrating because it's in a mild dosage and they perform well under it, at least for now. You can see the example here, in this example here, that we'll hear a symptom, and because of our own experiences and biases or whatever else, will immediately think of a particular disorder, but there could be lots of disorders that cause that same symptom. To further complicate things, we have to contend with sociogenic illness and media influence. Here's a great example, the TikTok ticks. Pediatric specialists worldwide reported increases in functional or conversion disorders with tick-like behaviors, and the patients involved reported seeing TikTok videos of Tourette syndrome prior to the onset of symptoms, suggesting disease modeling. Now, what was interesting in this study is that the symptoms that people are presenting with are not common symptoms in Tourette's, but they look that way in TikTok videos. Like, for example, arm movements versus facial movements, um, corporalia, which is, if I remember right, with the shouting of obscene words all of a sudden and that sort of thing, and also self-injurious behavior. So these, all of a sudden, we get an influx of especially teenagers and young adults presenting with tics. They think they have Tourette's, and they're showing symptoms that are not commonly associated with tic disorder. Now, I am not suggesting to you that those kids and adults were lying. I mean, some of them may have been feigning intentionally or exaggerating for various gains. There are disorders that can be diagnosed for that, for example, like factitious disorder. Um, or they could be malingering, which is not a disorder, but it is a diagnosis in the DSM. The difference between malingering and factitious disorder is that the incentive um, is more either material in nature or more pragmatic in its nature. Like I'm feigning schizophrenia to dodge the draft during the Vietnam War, or I am feigning PTSD to win a lawsuit settlement. That's intentional and that's not a disorder. But I think that most of these teenagers and young adults truly were experiencing tics, which were caused by sociogenic variables. They took on identities because they related to or liked other people that they saw on social media. They know something's often wrong with them. They start to subconsciously and unintentionally mimic those same symptoms and then get concerned about them and present with them. So I'm not suggesting that they're all lying. I'm saying that literally the cause of some of their disorders was watching something on social media. Similarly, many of you can probably attest to this. I certainly can in my own practice. Increases in teenagers and young adults who want an evaluation because they think they have ADHD, autism, dissociative identity disorder, borderline personality disorder, bipolar disorders, or gender dysphoria. Um, and I'm going to pause here and say, please do not hear what I'm not telling you. I'm not telling you that gender dysphoria is not real. I'm not telling you that bipolar disorder is not real, or that ADHD is not real, or that autism is not real. I'm also not telling you that there are not lots of people out there who have these conditions that are not getting diagnosed or getting the treatment they need for it. Because that's true. There are people that are undiagnosed or underdiagnosed that are not getting the help they need. I am suggesting to you that sometimes these are sociogenic manifestations. To give you an example with gender dysphoria, I've had teenagers who come in and they're like, yeah, I think I'm transgender, or I think I'm gender non-binary, or I'm gender variant, or I'm gender dysphoric or whatever. And I'll ask some questions and like, when did this start? Well, last week. And then what happened last week? Well, I met this friend and they identify that way. And I thought they were really cool. And I thought, I've kind of always felt a little uncomfortable with myself. Oh, that must be what's going on. And then like 3 months later, they're like, oh yeah, no, I don't identify that way. That I was wrong about that. So that, I mean, that obviously there's some degree of social influence that we get, but sometimes we develop something that does absolutely seem, feel, and for all intents and purposes is real to us, but its etiology, its cause is not from birth. I felt like I was in the wrong shell, or maybe the cause is not a brain or abnormality of executive functioning, but the cause is I've taken on traits and characteristics through social influence that otherwise I would not be experiencing. That does happen sometimes. And that makes things complicated because sometimes these clients will come in and they already know all the diagnostic criteria of autism. So they just tell you yes to every symptom. And so you have to get deeper and look at, does this manifest in other contexts? And in what context does it manifest? And what are the exceptions to it? And when did all this stuff start? And it gets pretty complicated. And also, there are people who are truly gender dysphoric and were not aware of it until they met somebody who was experiencing something similar. So I'm not suggesting, again, that these are not real conditions, but I'm saying this complicates the picture for us, sociogenic transmission of symptoms. Lack of training and experience, like Rama brought up, is another barrier. Time restrictions. You might have 45 to 60 minutes to do all kinds of things: solicit informed consent, complete a biopsychosocial assessment, conduct a diagnostic interview, build rapport, orient them to therapy, offer them some hope, answer their questions, and discuss how to get started. That's a tall order in 45 to 60 minutes. Um, and it's not pragmatic to do a deep dive into differential diagnosis in that context sometimes. Clients can be poor historians, they can be defensive, they can be slow to warm up and to trust you, they can be shy, they can be very verbose and tangential, kind of like I am on this presentation today. And then because of that, it takes you forever to get through a diagnostic interview and you can't get through the whole thing in one session. And so here's our first tool of the 7 tools. We're halfway through and we've gotten to 1 out of 7 tools. Yay! We'll move faster though now that we've gotten into the tools. Have a good intake packet. Now, there's a drawback to this. I mean, who likes doing paperwork before they even met the therapist? And you could argue that privacy-wise, people are giving you a lot of information about themselves when they don't even know you yet. My experience is they're used to having to answer a lot of questions before they see someone now. I mean, the number of forms that I completed a couple weeks ago just to see a dentist for the first time. Also, I went for the first time in my life to see a chiropractor recently. There was a lot of stuff I had to fill out. I feel like everyone's just used to this by this point, and they already know they have to, write a dissertation to do their first appointment. You can try to make it very quick and easy and succinct with very few fields and accepting short responses from people. Let them select between different options instead of having to write big, long explanations and stuff. But you can hit on a lot in that packet. Because I'm going to tell you a story. In a clinic I worked in many years ago before I went into private practice, there was an elderly woman who was meeting with me for her intake. Now, she was a Medicare patient. I'm an LMHT and an LMFT, and we didn't get Medicare rights until recently. So you might ask, well, why was I doing a Medicare intake? Because what this place did was LMHTs did all the work, and then LCSW signed off at the end, and that's how they billed Medicare. So that was the way it was done. And so I'm doing her intake, and I have, it was like a 20-page biopsychosocial packet that we used for all of our Medicare clients. Why? Because Medicare requires that you have lots of certain kinds of information in the client's file. And they think, well, that's something the therapist can collect during the initial interview. Problem is, she comes in, she sits down, and immediately starts bawling. And in between the tears and the gasping for breath, she tells me that she just lost her husband of 50 years. 15 minutes later, she's still crying and trying to tell me some stuff about what happened with her husband. And I'm on page 1 of 20 in the psychosocial assessment. And I'm now sweating and getting nervous because I'm like, oh my gosh, I'm never going to get through the 20 pages. I certainly will not get to that question that asks her what her favorite class was in high school, 35 years ago or whatever it was. That's completely irrelevant to what she's coming for today. But if I don't get through this, I'm going to get in trouble because I'll get in trouble if I don't get through the psychosocial. And Medicare can get mad at us if they audit us and we cannot get paid for things and stuff can happen and heads might roll. And what I really wanted to do was to join in with her, hear her story, be a good empathetic listener, to show her that I'm truly trying to understand on some level what it's like to be in her position, give her a sense of hope to come back for the second appointment so that we can grieve together. And instead, I'm grilling her for 20 pages of an assessment. That's not a good way to practice. And unfortunately, that's the way it is in the field many times. My opinion was we could eliminate a lot of this by having them fill this stuff out before they ever come in and see me. We already know what their favorite class was in high school if for some reason Medicare wants to know that or whoever else. And so that's already covered. We already asked them that. It's already in the file. And then the therapist looks that over before they see the client. They maybe mark a few things that they want to ask some follow-up questions about, and they sit down and they get to be a present human being who connects with a person and builds rapport and orients them to therapy, does their diagnostic interview, gives them a sense of hope on what we could do maybe after this first appointment. And it gives you the time to do all of that if you've already collected a lot of the stuff that third-party payers require you to have on file. I'm not saying that it's bad that third-party payers require you to have this stuff on file. It could actually be a really good thing. It could prevent medical errors. But I don't think that you need to spend your first appointment interrogating people either. Now, of course, there are drawbacks to this approach because you might work in a setting where clients don't do well with paperwork or they don't know how to read or write well. So I'm not suggesting that this is bulletproof, but in most independent practices, clients can answer a lot of this stuff very succinctly before they come in and see you. So you might have something like there's a tool called the Adult Checklist of Concerns that you can Google. And it's just a one-page alphabetized list of a gazillion different concerns that people come to therapy for, and they check off everything that applies. You would be amazed how often they check off stuff that they don't organically tell you about in the first appointment. When it's there on a checklist, and all they got to do is check it if it applies. You can, of course, ask about their mental health treatment history and family treatment history, their family, social, and relationship history, educational, vocational history, legal history, medical history, including hospitalizations, medical concerns, problems, medications, insurance status, most recent exam and blood work, substance use history, and you could even use a mental health symptom screener like the DSM-5 TR cross-cutting symptom measure level 1, which would help to make your interview much more concentrated and focused on the things that you already know could be a disorder that they might be diagnosable with because you've already gotten that screening done before they even saw you. So I think it's a great tool to consider. So our second tool is really two different resources. One is a book entitled DSM-5-TR Made Easy by James Morrison. A lot of people have found it to be a pretty useful book in terms of the information it offers about differentiating one disorder from other disorders that might have similar symptoms. But I'm a big fan of going straight to the DSM-5-TR. And let's say that you're thinking that it could be that the client could meet criteria for a particular disorder, but you also kind of recognize, gee, these symptoms can also exist with some other disorders. How do I know which one it is? If you go to that disorder in the DSM-5-TR, you will see a section called differential diagnosis for every disorder. And there you'll find that the APA's task force has described other conditions that oftentimes can be confused with this particular disorder because of overlapping symptoms. And it will describe how you differentiate this disorder from those other conditions that are very similar to it. So always go to that section of the DSM and just read through it and make sure that you've really clarified some of those things. That works in the case of like the ADHD scenario I was giving earlier, where somebody might have all the symptoms that somebody with ADHD will report that indeed are in the DSM, but it's really anxiety and not ADHD that's causing the symptoms. And so if you go to the DSM-5-TR and you look at ADHD and then you go to the differential diagnosis section, and it actually does give you some useful information about how to differentiate whether the ADHD-like symptoms are better conceptualized as a diagnosis of ADHD or as an anxiety disorder diagnosis. And essentially what it kind of talks about is, do these symptoms manifest only when the client is feeling nervous, anxious, worried, tense, etc.? Or do we see this cross-contextually in situations where they don't have that anxiety, that nervousness, that tension? Um, so the differential diagnosis section of the DSM-5-TR can be very helpful. Morrison, in the book DSM-5-TR Made Easy, offers what's called the safety principle of diagnosis, When engaging differential diagnosis, first rule out substance use as the primary cause. Second, rule out other medical conditions. And you might be saying, well, I'm not a physician, so how do I rule out other biomedical conditions? And like I was explaining earlier, that could be asking the client whether they have seen a physician about these symptoms and had a medical evaluation. And if they have not, referring them to one. And in some cases, getting maybe a copy of those medical records to help you rule things out. There have been a couple times where a client told me, "Oh yeah, no, I don't have any medical." In their intake form, they say they have no medical conditions, and then I get a copy of their medical record, and there's a hypothyroidism diagnosis. And I'm like, gee, no wonder they've had this stubborn. I've literally had a client where they were like, I have been to so many therapists over the years, and no matter what they do, I always seem to still struggle with the depression. And they did not even know that they had a diagnosis of hypothyroidism in their file. That's weird, but it happens. So th those are ways that you can rule out other biomedical conditions. And of course, again, a client may either refuse to follow through with a medical recommendation, or they may not give you the information you want, or they might falsify information, but you didn't do something wrong when that happens. You did your job, which was to ask or explore these things with the client and document it, so that later on it can't be alleged that you did not screen them. One time I was working with a family who was meeting with me because they were looking for an approach on how to address another family member's alcoholism. And one of the family members who was meeting with me died. And one of the other family members came to me and said, "You may have picked up on this, but that other family member was also a severe alcoholic, and so they died from their alcoholism." And I was like thinking to myself, no, I did not catch on to that at all. I had no idea that I've been meeting with this family, and that one of the family members I was meeting with to get advice on how to deal with another family member's alcoholism was themselves a very severe alcoholic. And then I thought, ooh, did I miss something? And then I went back to my questionnaire, which asked them questions about their substance use, and they had denied drinking large amounts of alcohol or having any concerns with their drinking or any problems with it, etc. And since I wasn't evaluating that individual and I was really consulting with them about their family member, I didn't dig deeper into it, but I did ask, and they did provide inaccurate information. Now, if you will excuse me, my dog is barking very loudly, so I'm going to let him back in real quick. I'll be right back. Since I had to interrupt this to let him out, I'm just going to show you his adorable face here, so you know he's real. Okay, so third, consider conditions that are the most treatable and therefore should be addressed early. And then finally, consider conditions with a poor prognosis that are difficult to treat. And so the third and fourth steps there are really like triage recommendations. Where do we start if somebody has more than one condition? But I like to talk about this model instead, which is the model offered by the APA. And here I'm going to give you two additional resources for a third tool, the DSM-5-TR Handbook of Differential Diagnosis, which gives you even more information about differentiating disorders that might have overlapping symptoms. There is an app. It's an expensive app. It's $69, and it's the DSM-5-TR Differential Diagnosis app, and it actually has decision trees to help you with the diagnostic process. And what that app is trying to do is to walk you through a 6-step differential diagnosis process. Here are the 6 steps recommended by the APA. The first is to rule out malingering and factitious disorder. And you know how often people will just assume that the client is giving us accurate information. Well, have you ever had a client that like they'll do a symptom checklist 90 revised or a brief symptom inventory, and they'll like top the charts on everything across the board? That's not because they have every disorder under the sun. That could be because they kind of have a dramatic personality where they exaggerate things and catastrophize things. It could be that they're feigning illness, or it could be that they maybe have a sort of somatic symptom presentation or something along those lines. There are different explanations, but it doesn't mean they have every disorder just because they're endorsing a large number of symptoms. So we forget about step one in the world of therapy a lot of times because we just kind of assume that whatever our client's telling us is accurate when it sometimes or oftentimes will not be. I do the opposite. I assume that my clients, even when they're not intending to be, will be inaccurate in what they tell me, because that's normal. When we look at the literature, most clients admit in surveys that they've either intentionally falsified information they've given their therapist, or sometimes just kind of unintentionally did it, in hindsight. Um, they might kind of underreport how many drinks they've had. They might kind of underreport how often they, or overreport how often they exercise, or any number of small distortions, but sometimes they're bigger ones. And that's okay. There's no judgment about that in my mind. I'm not here to judge any client. It's normal, for them to do it. I just have to remember that when I'm working with them, right? Rule out substance etiology is actually step two for the APA and the DSM-5 TR handbook. That includes drugs of abuse and medications. I'm going to give you a case example of these. So we're going to walk through these and make better sense of them in a moment. Third is to rule out, could this mental disorder be being caused by some kind of biomedical condition, like the depressive disorder due to hypothyroidism? And the fourth is then, after doing those first three things, you determine the specific primary disorder, and then you differentiate adjustment disorders from other specified or unspecified disorders. And then finally, you establish the boundary with no mental disorder. Because I could have every symptom of a major depressive episode, except it's not causing me clinically significant impairment or distress. And if that's the case, I don't have a disorder. I might be a guy who has less interest or pleasure in things that I normally enjoy. And I might feel significantly sad most days. And I might have sleep disturbances and appetite disturbances. And I might be okay with it and be functioning well also. And be like, it's okay. I kind of have a sort of depressive mind. And actually, there's some kind of good things about that too. And I mean, it's hard to imagine, but there sometimes are people who have the adequate symptoms that you see in criterion A, but they don't have clinically significant impairment or distress and therefore do not have a disorder. So ruling out malingering and factitious disorder, some questions to consider. Are there clear incentives for a diagnosis? Is this somebody who would benefit from having a diagnosis, like they're involved in a lawsuit related to the symptoms they're expressing? Are they applying for disability? Um, those could be examples, and that doesn't mean they're malingering, but they're just things to consider that there would typically be a motive. Does the patient present with a cluster of symptoms conforming to a layperson's perspective of mental illness? Even more interestingly, a symptom that most people associate with the disorder that actually almost never happens. Like here's an example. PTSD. If somebody has had a traumatic experience and they develop PTSD, many people out in the general public, especially those who may be trying to feign PTSD, know that people with PTSD will often have flashbacks or nightmares. They may not know, though, that those flashbacks and nightmares are not exact replicas of the traumatic experience, because that's less well known. So they may say, yeah, I had this traumatic experience where I was in this accident and this thing happened, and I have dreams, and it's like it's all happening again from the very beginning to the end in pristine detail, exactly the way it really happened. And that would be weird. What's more common, I'll give you a case example. I worked with a firefighter who um, tried to rescue a child from a car that went over the side of a bridge over relatively shallow seawater. And let me get this off the screen here. There we go. And so he tells me about a nightmare where he's at a beach that's in like a very Caribbean place because it's got that really nice turquoise water that we don't have in the Tampa Bay area, but that some of you, if you're in the Emerald Coastline, might have, or maybe you're in Key West or something. But um, and he's like, so I was at this beach and I saw this kid with like a snorkel swimming around in the water, and then I saw a shark fin, and the shark fin was headed towards the kid, and then I jumped in the water and I was swimming, but no matter how hard I tried to swim, it's like I was getting further away instead of getting closer. And then I was yelling for the kid, but the kid didn't hear me. And then the next thing I know, the snorkel disappears, and then the shark goes underwater and just seems to be dragging the kid away, and I couldn't do anything. Well, that has elements of the original traumatic experience, but it's not an exact replica of a car going over a bridge into seawater and then a child being trapped and then him not being able to save the child in time. But it's got a lot of the elements, doesn't it? That's more common with PTSD. Does the nature of symptoms shift radically from one clinical encounter to another? Like, oh, gee, they learned or read that, people with this disorder might be more, might have a harder time trusting or be more paranoid. And so all of a sudden they're acting more paranoid or untrusting. Um, and does the symptom presentation mimic that of a role model in their life? And then is the patient characteristically manipulative or suggestible? And I would now add the question, what have they been watching on TikTok? So it's what does their feed look like? And does there seem to be a connection between symptoms they're reporting and things they just recently started encountering through social media? Or maybe the symptoms did not predate the encountering of those. And you don't want to ask it as clearly as, um, did you see somebody on TikTok with these symptoms or something like that necessarily, but it might be, yeah, I've seen people on TikTok and I saw these symptoms they have and I relate to it. And you might ask when the symptoms started. And then later on, you might ask, when did you start seeing the videos on TikTok? And you might find that the videos on TikTok precipitate the experience of the symptoms themselves for the client with a condition that normally would have manifested before then. It's just as an example. All right, so the second step is ruling out substance and medication-induced symptoms. What do you think you might be able to ask to try and rule out whether their symptoms could be being caused by substance use or medication for that matter? I'm gonna check the chat box here. We have Linda loves my dog. That's what we got in the chat box. But anybody have any thoughts about how would you rule out that maybe their symptoms are being caused by substance use or medication? A drug screen. Well, yeah, that's a possibility. I'm guessing most of you don't do that. In my practice, we do drug screens, but we don't drug screen every client who comes in for therapy. We usually only do drug screens for clients who are mandated in some way, and we are trying to document their abstinence or sobriety using some extra methods and means. But drug screening would be a way to go about it. Looking at medication interactions, absolutely, Rayma, and common side effects. Yes, yes, and yes. You should know what their medications are. That should have been a question that you asked them or that they filled out in their intake packet. Or maybe you got a medication list from their physician or prescriber. And then you look at the symptoms and you're like, huh, I wonder, are these symptoms common side effects or of that medication? Which came first, the medication or the symptoms? And that can be one way to start exploring some possibilities as well. Part of it's collecting a thorough substance use history, though. So, are they using any substances? Do they used to be using any substances? When did that substance use start? How often are they using it? Which came first, the substance use or the symptoms they are reporting right now? It's about time frames as well. What what are there any diagnosed biomedical conditions? What's the etiological relationship between the biomedical condition and the psychiatric symptoms they're experiencing? This is for step three. Sorry, I forgot to tell you. We're moving on to step three here. Rule out a disorder due to another medical condition. As far as the etiological relationship goes, let's take hypothyroidism and persistent depressive disorder, for example. You have a client and they seem to meet the symptoms for persistent depressive disorder, but you find out they also have hypothyroidism. Um, it could be that the hypothyroidism is causing the depressive symptoms due to direct physiological effects of that condition on the brain. Or it could be that the hypothyroidism is causing the psychiatric symptoms through some other psychological mechanism. Like, for example, I found out that I have cancer, and because of that, I'm depressed. Well, that doesn't mean that the cancer cells are creating the depression directly. It can be a psychological reaction to having cancer instead that is causing the depressive symptoms. Or it could be that I'm taking a medication for that medical condition, and that my depressive symptoms are a side effect of that medication. Or it could be that my psychiatric symptoms are actually what's causing the medical condition. Like, what if, um, I don't really know if this is a real thing, but what if my thyroid was perfectly healthy and normal until I got really depressed after my spouse died, and then my thyroid levels started to get out of whack? Could psychologically, could depressive episodes triggered by adverse experiences in life create a change in the thyroid that causes the hypothyroidism? I don't think it can, but maybe it can. I don't even know, to be honest with you. So these are the relationships you'd have to investigate and explore and research. And usually your answer is just a quality Google search away. Certainly, consultation with a medical professional that's working with the client can be another possibility. I'm going to show you some other resources where you can find out the answers to some of those questions in a moment. But also, psychiatric symptoms and the medical condition can just be merely coincidental. They don't really, neither one causes or makes worse the other. They just both happen to be having alongside each other. So these are all possibilities about relationships between their medical conditions and their psychiatric symptoms. If the medical condition is what is responsible for the psychiatric symptoms, then you're probably going to be diagnosing the mental disorder due to another medical condition. For example, in the depressive disorders chapter, you'll see the diagnosis depressive disorder due to another medical condition. And if they're hypothyroid, if the evidence suggests that the hypothyroidism is causing the depressive symptoms, then that would be your diagnosis. It wouldn't matter that they otherwise would meet criteria for major depressive disorder. That's not going to be your diagnosis because there's a if you look at the diagnostic criteria for major depressive disorder, one of them is that the symptoms are not better explained by another medical condition. In that case, if they are better explained by hypothyroidism, then your diagnosis would be depressive disorder due to hypothyroidism. You take other medical condition, you replace that phrase with the medical condition itself. You're not going to do this as a 491 board licensee unless you have that medical documentation, because you cannot diagnose hypothyroidism. It's out of your scope of practice. Unless we have a physician, a psychiatrist who's on today, I don't think any of you can diagnose hypothyroidism. But if you have their medical record and it says right here hypothyroidism, and all the evidence suggests that the depressive symptoms that they're experiencing are common symptoms of hypothyroidism and that the hypothyroidism predates the depressive symptoms, if that's where the evidence takes you and you have that diagnosis on file, then by all means, depressive disorder due to hypothyroidism would be your diagnosis. And you're using the diagnosis of hypothyroidism that you got from a specialist in that area to arrive at that diagnostic impression. Couple of resources that are good to know about. Medscape is a great resource. You can go to medscape.com and you can sign up for a free account with them. And you can do it under the specialty area of psychiatry so that you get tailored, your information is tailored to mental health. You do have to document that you are a healthcare professional, and then you get a free account. And there's all kinds of cool free trainings and all kinds of stuff that you can get with your free Medscape account. But one of those cool things is get the Medscape app, and it's got a great medication database. Type in the medication the client's taking, and then click on adverse effects. And for many medications, it will tell you the percentage of clients who take that medication who experience certain adverse effects. Does that list of common adverse effects match the client's symptoms that look like depression or look like whatever else? And if so, did the medication start before the symptoms started? And if that's the case, you might have a substance or medication induced depressive disorder instead, in that scenario. You can also look up interactions. Here's where you'll find out that sometimes your clients are using medications that are known to negatively interact with each other, or they are using recreationally substances that can interact very negatively with the medications they're taking. That app is good to figure that stuff out as well. There is also a great book written again by James Morrison, When Psychological Problems Mask Medical Disorders, a guide for psychotherapists. And it's a book that will provide you with information on a lot of medical conditions that commonly create symptoms that look like mental disorders that are not necessarily always caused by medical conditions. So also another good resource. But frankly, you can get a lot of this information online for free these days as well. Just make sure that you're getting it from a quality source. Step 4 in the APA's process is to determine the specific primary disorder. And here I recommend that you use the decision tree that they've provided. You can, instead of using the decision tree, you can examine the diagnostic criteria line by line and make sure that the client meets those criteria. And you can go to the differential diagnosis table to ensure all other likely contenders have been ruled out. Step 5, differentiate adjustment disorders from other specified and unspecified categories. In general, you diagnose, now I do think adjustment disorders are probably overdiagnosed in private practice because a lot of people are like, gee, my client sounds kind of depressed or anxious. Either A, I don't have time to dig into it deeper, or B, I have the philosophy that I don't want to unnecessarily diagnose my clients with a more severe condition. So I'm just going to slap on an adjustment disorder diagnosis and call it a day. I would argue that's not okay to do. It's called misdiagnosis in some cases, and in other cases, it is also insurance fraud. It might be what's called downcoding, which is I'm going to say they have something less severe than what they probably have for whatever, I might have good reasons in my head for that. But you only diagnose adjustment disorder if A, they do not meet the criteria for another mental disorder, and B, their symptoms appear to be intimately connected to one or more acute psychosocial stressors that either A, have not yet been resolved, or B, it's been less than 6 months since they've been resolved and they're still kind of rebounding from the experience. So I'm going to explain that a little bit more. If your client says, I retired 2 months ago, and after I retired, I started feeling like I don't really have a purpose in life. And now I feel significantly sad, down, and depressed more often than not. And I have difficulty concentrating. And I've had suicidal thoughts. And I also have a lot less interest or pleasure in things than I used to. And I don't have much of an appetite anymore. And I've lost weight without trying to. And now I'm getting kind of underweight. And and also I'm having a hard time sleeping at night. Do you adjust them or do you diagnose them with adjustment disorder with depressed mood? Their symptoms started after retirement. That seems to be the trigger. They see a connection between the two. They know they lost their sense of meaning and purpose. Now life seems pointless. So do you diagnose them with adjustment disorder with depressed mood? Who says yes and who says no? Any brave souls want to answer? Further assessment needed? Okay, Raymond, that's great. But
I,
what would tell you? I mean, I would tell you actually from just what you've heard alone, the answer is already probably no. You would not diagnose him with adjustment disorder with depressed mood. Why do you, does anybody know why I would say that? Because they're suicidal? Well, not just because of that. You could say that's part of the case for why you would not die. I mean, you can have adjustment disorder and be suicidal. That can happen. And it has happened. I've actually seen it happen. But there's another reason why you wouldn't. A better reason why, I think. Because they meet criteria for a major depressive episode, right? They've felt significantly sad, down, and depressed more days than not for longer than 2 weeks, and they meet a sufficient number of symptoms of a major depressive episode to be diagnosed with a major depressive episode, which means unless they have bipolar disorder or schizoaffective disorder, we would probably go with major depressive disorder. Why would we not do adjustment disorder? Because adjustment disorder is for when they have, with depressed mood, is for when they have depressive symptoms that are shy of meeting the criteria for a major depressive episode, and those depressive symptoms are causing clinically significant impairment or stress, and they appear to be intimately connected to one or more acute psychosocial stressors. That's when you would do adjustment disorder, depressed mood. That's a common misconception people have is if it seems like it's a reaction to a thing, it must be adjustment disorder. No. Some of us have very depressive brains, and certainly retirement can trigger a major depressive episode. Certainly the loss of a loved one can trigger a major depressive episode. Um, Lots of life experiences can trigger a major depressive episode with a person who already has a propensity, a predisposition towards depressive mood. So there's no rule that says that depressive episodes are never triggered by life experiences. They often are, actually. That's very common to see with major depressive episodes. Um, you know, so you get the idea here. You have to learn how to separate adjustment disorder from other mental disorders and also from other specified and unspecified. So now let's say that my client has had all the symptoms I just told you about, except the symptoms started 9 days ago. Now what do we do? Because for a major depressive episode, you have to have at least 2 weeks of symptoms. So this client's had suicidal thoughts, significantly sad down and depressed more days than not, difficulty concentrating, weight loss, loss of appetite, anhedonia. Go down the list of depressive things. They're experiencing it. You name it, they're experiencing it. And yet it's only been 9 days that all this stuff's been going on. Well, that might be an adjustment disorder. I don't think so, actually, though. I think what I would do is I would go with other specified depressive disorder, comma, does not meet full duration criteria for a major depressive episode. That's what I would do. Why? Because an other depressive disorder diagnosis means that an individual has the symptoms of this family of disorders, but they're just shy of meeting the full criteria for a specified reason. And in that case, the specified reason would be time frame. That's actually an example that the DSM gives of when you would use that diagnosis. It's too severe to be adjustment disorder with depressed mood, even though it's not been long enough to be a major depressive episode. So I'd go with other specified. Unspecified is the same thing as other specified, except you're not going to tell anyone why. So I honestly, the DSM task force frowns upon using it, and they would prefer that people not use it. And yet I see it all the time. I jokingly call it the lazy therapist diagnosis because it's when either people use it when either A, they ran out of time and they couldn't refine the diagnosis, or B, they're not really sure which disorder it is, or they know why it's not a disorder, but they don't want to write about why. So they just tack on unspecified. If you do other specified, you have to add the reason why after a comma at the end. Other specified depressive disorder, comma, does not meet full duration criteria for major depressive episode. That's a lot of writing, and so people get lazy and they don't want to do it, and they just say depressive disorder unspecified, and that's the end. Or I'm saying that tongue in cheek because sometimes it's not that they're lazy, it's that I truly do not have enough time with this person to refine this diagnosis. And so I did unspecified instead. But you might instead do a provisional diagnosis, and make it very clear that you're doing a provisional diagnosis of unspecified depressive disorder in that case. Anyway, I'm getting into the weeds of the details here a little too much. Let's move on to step 6. Explain the boundary with no mental disorders. And here you're looking in for most disorders, there's a requirement that they have to be experiencing clinically significant impairment or distress. Not all mental disorders, but most of them in the DSM have that. So what's the difference between the two? Impairment is about how it's affecting their ability to function. Is it affecting their ability to work? Is it affecting their ability to maintain social relationships? Is it affecting their ability to keep up with their household chores and duties? Is it affecting their ability to take care of their own hygiene? A lot of therapists make the mistake of not asking about that when they diagnose somebody. So I like to practice this way. I like to imagine that I'm on the stand in court and I have to show and explain exactly how the client meets the full criteria. And there's always going to be that, well, how do you know that they have clinically significant impairment or distress question? Can you answer it? Can you say, oh, because their grades have been slipping at school, and they connect that to their difficulty getting out of bed and going to school, or whatever else it might be. Now, if not impairment, it has to be distress. And that one's a little bit easier to argue because probably if you're in private practice, for example, and they're choosing to go see you of their own volition, they're probably experiencing clinically significant distress. Because distress is just about internally how much are they suffering. And when they say, I'm really, really bothered by this, then that's their way of saying I'm really distressed, right? So that's a lot easier. Now, you can document that also sometimes with scales that you might use that show that they meet a certain like quantifiable number that generally would be considered clinically significant. That's another way you can do it. But impairment, it's interfering with my ability to function. Distress is internally, I'm suffering because of this. A fifth tool in our list of 7 tools is the use of various tests and measures. I gave some examples, but there's like a million tests and measures. I have a whole training on tests and measures, and uh, I feel like we did one with Samka in the past, maybe, but um, I like to use the PAI Plus in my practice a lot because it's a very broad test that covers lots of clinical domains, and it even gives you statistical evidence of increased likelihood of feigning or exaggerating of symptoms or minimizing and underreporting symptoms, sweeping them under the rug. The problem for a lot of frontline clinicians is they're not going to use this test because it costs money. It's not free. And if you're only getting paid a certain amount for a first appointment and you want to do it, have the client do a PAI, either they're paying for it or you're paying for it. Um, and then you're adding a charge to the client beyond their copay. Now, in a different training, I talk about how you can bill insurance for testing if you are contracted with the insurance company to for those CPT codes. And then that helps offset the costs of tests and measures for the client and for you. But especially when you have clients who have the ability to pay, there's nothing stopping you from using more sophisticated tests that would cost money. But I'm going to show you free options as well in just a moment here. The sixth tool is collateral sources. We talked about that before, and that's people you might interview or records you might review that can give you more information to help you with your differential diagnosis process. The seventh tool, which is brand new to this training, is generative AI tools. So some of you were at the generative AI training that I gave. I feel like it was very recent, December or November with Sanka. I don't even know. I'm giving that training a lot these days. And I give examples of ways that you could harness the power of generative AI to try and help you with a differential diagnosis process. I also give lots of risks associated with it and ethical and legal considerations, as well as clinical considerations, because these tools are only as good as the prompts that you feed them, of course. But here's an example of a prompt, and I'm going to paste the prompt from that slide. I'm a mental health counselor conducting a mental health evaluation of a client. Her symptoms include depressed mood most of the day, nearly every day for 2 weeks, difficulty falling and staying asleep, daytime fatigue, a sense of worthlessness and hopelessness, reduced appetite, and unintentional weight loss. What disorders might be potential diagnoses for her? Let's ask Professor ChatGPT and see what response we get. Um, Based on the symptoms described, it could be major depressive disorder. And they actually showed you from the DSM-5 symptoms of major depressive disorder that you included in the list of symptoms that you gave. Now they say rule out the possibility of medical conditions, substance use, or bereavement as contributors. Number 2, persistent depressive disorder, if they've been lasting for 2 years or more. Now I said in my thing here that it was for 2 weeks. But what if some of these symptoms have been going on for 2 years? And what if those symptoms are enough for persistent depression? This gets technical, but they might meet criteria for persistent depressive disorder with intermittent major depressive episodes, with current major depressive episode severe, for example, right? Which is a mouthful, but that is a long DSM-5 TR diagnosis, a real one that I just gave you with a bunch of specifiers tacked onto it. And that's when somebody has had persistent depressive symptoms for at least 2 years. And sometimes those symptoms are enough for a major depressive episode, and then for a while they may not be. They're just mildly depressed, not enough for a major depressive episode. Um, but right now they're having a major depressive episode for the past 2 weeks. But if you trace their depressive symptoms, they actually started 4 years ago. Well, that would be persistent depressive disorder, and ChatGPT knows that. So next, adjustment disorder with depressed mood. If they're linked to a specific life stressor and do not meet the full criteria for MDD. So ChatGPT knows what a bunch of us did not know a few minutes ago, right? That in that adjustment disorder scenario I gave you, we wouldn't diagnose that client with adjustment disorder with depressed mood because they seem to meet the full criteria for a major depressive episode, and therefore we would go major depressive disorder instead. But ChatGPT does know that because it knows everything that's in the DSM-5 TR. Other depressive disorders, if the symptoms don't fully meet MDD or PDD, consider these categories. What I wish it would do is tell us more about, well, how do I differentiate whether it's those two? Good news, we can ask it. How, in this scenario, might I differentiate between those two things? And what questions could I ask during my next appointment? Now, before we look at its answer to that question, note that it also already gave us some examples of ways that we could assess further, we could further differentiate between these different depressive disorders. It's saying, well, during the clinical interview, find out how long this has been going on and when it started, and whether there are any triggers of these symptoms, and assess for stressors, current life stressors, trauma, changes in circumstances, gather medical, substance use, and family history. Just like I've been telling you all this time, right? You could have saved yourself this whole training and just asked ChatGPT, huh? Screening tools, consider the PHQ-9. That's a free tool based right off of the DSM criteria that's commonly used to screen for depression and to measure progress over time with relief from depressive symptoms. Recommend a physical exam. I like how it didn't tell me do a physical exam. It knows I told it I'm a mental health counselor. It knows mental health counselors probably don't do physical exams. So it's telling me to recommend one and lab work to rule out medical conditions like thyroid function. I couldn't have said it better myself, right? And oh, by the way, you better like assess for suicide with this client. I'm glad that it's telling us to do that. Can you argue with what it's telling us here? I don't see how. I think it gave us a really good answer. ChatGPT does not always give you a good answer, but sometimes it does. A lot of times it does, especially if you give it the right information. Now, notice I asked the follow-up question, well, how do I differentiate between other and unspecified? It says used other specified when the depressive symptoms cause significant impairment but do not meet the full criteria for a specific depressive disorder. And specify the reason why the criteria are not met, such as short. That's exactly what I just told you a few minutes ago, right? Example, a depressive episode lasting less than 2 weeks or missing a few required symptoms. That's exactly what we were saying a few minutes ago as well. Unspecified is used when depressive symptoms are present impairing, but the clinician either lacks sufficient information or does not want to specify that exact reason why. And then it gives us here's some examples of questions that you can ask to assess all these different things that it suggested we check into. Look at that. So that's your tool number 7. And chat, remember though, I say this in the other training, never put anything into Chat GPT that could even remotely potentially identify a client. Don't put too much personal information about a client in there. ChatGPT doesn't need to know where they live or how old they are. Well, maybe you could do how old they are, but it doesn't need to know where they live. That's not relevant to you getting the answer you need on this issue, right? Just put in the symptoms I gave it. Anybody could be experiencing those. It's not going to in any way even remotely identify a specific individual. So it's not PHI, and it might be okay for me to enter that into ChatGPT, but not my client is a 35-year-old white male youth pastor residing in Tarpon Springs, Florida, who was recently arrested for aggravated battery because ChatGPT, having access to an awful lot of information out there in the world, could probably connect the information you're entering to a specific individual who was reported in the news, or is on the public who's in jail website from Pinellas County jails or something like that. So be careful about what you're putting into it and how you're using it. But there's a whole other training on that, so we won't get too bogged up in that right now. So those are 7 tools. Now, I want to show you, we have time. Thankfully, we've got 33 minutes, so I can show you some examples of how to use the decision tree that the APA offers for differential diagnosis. Their decision tree starts with a list of syndromes. If you open their app, it will start, and you use the decision tree, it will start with this list. You look at it and you pick a thing that the client is presenting with. Maybe it's their primary concern, the main reason they're coming to see you. Maybe in your judgment, it's the most serious and important major thing that's going on. Or maybe it's just the thing you want to start with. But you pick that thing, that syndrome, so to speak. And then it's going to guide you through a list of questions to try and narrow down your diagnosis. First real case that we will use. This is the case of Bernadette, a 34-year-old female referred by a local hospital, where she was recently hospitalized in the psychiatric unit after an intentional overdose with her prescribed benzodiazepines. She was diagnosed in the hospital with bipolar II disorder. She reports mood swings, excessive daytime fatigue, significantly sad down most of the time for several months. She's anhedonic, which means she has limited interest or pleasure in things that she normally would enjoy. She has thoughts and feelings of worthlessness, passive suicidal ideation. So she's thinking about suicide and death, but she denies any intention or plan to actually harm herself in any way. She has an extensive history of difficulty maintaining relationships and a history of self-mutilation and suicidal gestures. She excessively worries about many things since adolescence, and her anxiety is accompanied with irritability and muscle tension. Where to start, right? There's a lot going on in this case. Um, so next, what I'm going to do is I'm going to play you a video. Oh, well, first question I have for you is, what do you think are some diagnostic possibilities? You're not saying that this is it or that you're sure. You just think it's a possibility to consider. What do you think could be some possibilities for Bernadette? Rama says medication interactions. Yeah, that is a possibility. What if it's the benzos or some other kind of medication that's producing all these things? What if that's what's going on? Anybody else? Diagnostic possibilities. Major depressive disorder or bipolar II disorder. Yes, those are certainly possibilities. She has mood swings. What if she has had one or more hypomanic episodes? Well, then it would be bipolar II instead of major depressive disorder. It could be other MOC medical condition. Oh, okay. I would do OMC, other medical condition then. Okay. Bipolar II, Brittany says. OMC, Rama says. Linda, I would want to rule out other medical conditions. Yeah, what if there's something medical going on? I mean, I'm going to go completely out on a. What if this was premenstrual dysphoric disorder? What if it was a what if it was a bipolar related disorder due to menopause or something? I don't even know. I'm certainly no expert in those categories, but what if, right? We don't know. So these are all things to consider. I am going to, and Rama adds hypothyroidism could be a possibility here. Yeah. Step one was rule out malingering. So we have to answer these questions on the previous slide I gave you with step one. Are there clear incentives for psychiatric diagnosis? None that we know of in the information I gave you, right? I didn't see anything about a lawsuit or a disability application, or there's this major responsibility that she's trying to avoid. Now, maybe they exist. We should ask. That's part of what a biopsychosocial assessment is designed to do, is to find out if there could be things that could be incentives, but there were none identified in this case. Does the patient present with a cluster of symptoms conforming to a layperson's perspective of mental illness? Well, not particularly. I mean, she's, I maybe a layperson would look at all those symptoms and say there's a specific diagnosis, but probably not. Does the nature of symptoms shift radically from one clinical encounter to another? No evidence of that. She's telling the same stuff to the hospital people that she's telling to me, and she's consistent with her story. Does the symptom presentation mimic that of a role model? None that we could identify. And is she characteristically manipulative or suggestible? We see no evidence of that. Um, Step two, has she been using one or more substances? Why, yes, she has. The scenario said she was abusing alcohol and benzodiazepines prior to hospitalization. Is there an etiological relationship between substance use and psychiatric symptoms? In other words, a causal relationship. And one way you'd find that out is which came first, the substance use or the symptoms. In her case, she started abusing substances in her mid 20s, but the psychiatric symptoms, as I said in the vignette, started in adolescence. So, no, there does not appear to be an etiological relationship. Now, that doesn't mean that her benzodiazepine use couldn't be potentially exacerbating her symptoms or conversely reducing them, but um, it doesn't seem to be the cause of her symptoms. Are there any diagnosed medical conditions? No, there are not. And what is the etiological relationship? Well, since there's no diagnosed medical conditions, we don't have to ask those other questions. Now we move on to using the decision tree. Remember that Bernadette's presenting symptoms include all these things. So we could take any of these and we could do a decision tree. And what I'm going to do, like if you look at these symptoms, this is the decision tree. There are a lot of things on this decision tree that we could a lot of decision trees that we could do with her. We could do one for anxiety. We could do one for depressed mood because she reported that. We do have some excessive substance use, hence benzodiazepine overdose. So we could do that one. We could do her report of irritable mood, the self-injury or self-mutilation, or we could do suicidal ideation or behavior. All of these are present with this client based on what you saw on this slide, right? So it doesn't necessarily matter which one you start with. Most people would start with the most important or the one they think is the primary presenting problem, but just pick the thing that you think is most important and do the decision tree. What does the decision tree look like? To save time, I've recorded a video of me using the decision tree on the app with this case. So let me show you that right now.
Book of Differential Diagnosis mobile app in order to use some decision trees to see if we can arrive at a diagnostic impression based on which clinical syndromes are present in Bernadette's case. We can see our 6 clinical syndromes that we identified in the case scenario here. Let's just start with anxiety. What I'm going to do is do some screen sharing and see if I can show you my cell phone. Here we are. Should now be able to see my cell phone. And here is the handy DSM-5 Handbook of Differential Diagnosis app. What we're going to do is, you see a few things here. One is, I do want to point out, see where it says step by step there in the middle of the screen, right there. If you were to click on that, you will see the different steps to differential diagnosis that we've talked about earlier. Just a side note, but we're going to click on decision trees instead, because that's what we're doing right now, a decision tree. And here are all of our clinical syndromes that we saw on the PowerPoint a moment ago. We're going to click anxiety as an example here. And notice that what you have in the middle here, there's always a box that kind of asks you a question and then allows you to click something. And then underneath it, there's going to be some explanation for that thing if you want to read that information before you make your selection. We're just going to hit start. And here's our first question. Is the anxiety due to the physiological effects of a substance, including medications? Well, remember, we have reason to believe that the answer is no, because Bernadette's psychiatric symptoms started prior to her using any substances. They began in her adolescence, and she wasn't using any substances then. And her anxiety was an issue in her adolescence. As a side note, later on in my work with this client, it became all the more apparent that even long after she stopped using substances, she continued to struggle with anxiety. So we're going to say no. Next question, is it due to the physiological effects of a general medical condition? Well, again, we have no reason to believe that's the case for this client, so we're going to click no. Is it occurring in the context of an abrupt surge of intense fear and discomfort that reaches a peak within minutes? This is your question that's designed to rule out whether this could be about panic attacks and could possibly therefore be a panic disorder. But no, her anxiety is not exclusive to panic attacks. So we're going to click no. Next question, are there recurrent unexpectedly clinically significant panic attacks? Again, the answer is no. Is the anxiety about being in places from which escape might be difficult or embarrassing in the event of having a panic attack or panic-like symptoms without more generalized worries? Well, remember, she has very generalized worries. So see that part without more generalized worries there? That's not the case for her. So we're going to click no. Anxiety or worry concerning separation from major attachment figures without more generalized worries. Again, she has very generalized worries, so we're going to click no for this as well. Anxiety or worry about social situations in which the person is exposed to the scrutiny of others without more generalized worries. Again, because she has very generalized worries, she worries excessively about a large number of things, we're going to click no, that her anxiety is not exclusive to social situations, as might be the case with social anxiety disorder. Is her anxiety about exposure to a feared object, such as spiders, or situations like getting an injection or flying? This is your phobia rule out question. And as with all of these, if you scroll down, you can read more information to help you make a determination on whether the answer is yes or no. But we're going to go with no because, again, her worries are very generalized. Is the anxiety about health and about having or acquiring a serious illness without more generalized worries? Well, again, we're going to have to say no for the same reasons we brought up earlier. She worries excessively about such a large number of things. This is not simply an illness anxiety disorder, formerly known as hypochondriasis. So we'll click no. Is the anxiety about discarding or parting with personal items resulting in the accumulation of possessions, cluttering living areas? This, of course, is your question that has something to do with hoarding or hoarding disorder as being a rule out. And again, her anxiety, we have no hoarding history with her and no reason to believe that her anxiety is exclusive to hoarding when it's very generalized. So we will click no. Is the anxiety or worry about an imagined defect in appearance? This might be the case with, say, body dysmorphia or with various versions of OCD, or sometimes with eating disorders. We're going to click no because, again, she has such generalized anxiety. Is the anxiety associated with your recurrent worries, thoughts, or ruminations? Well, yes, it actually is. Are these recurrent thoughts experienced as intrusive, unwanted, and ego dystonic? So this is where things get a little bit tricky. This is actually a rule out question for OCD. And I'm very tempted to click yes a lot of times. But when you have a situation where a client has very generalized anxiety, typically the answer is going to be no here. And the reason why is that some of her worries are things that she thinks she really should be worried about. She really does think that it makes sense to be worried about those things. So sometimes they're not really ego dystonic. Sometimes they're intrusive, sometimes they're not, sometimes they're wanted, sometimes they're unwanted. So we're going to click no. Is it excessive worry and anxiety about several agents or situations persisting for at least 6 months? Well, yeah, actually. I'm sorry, several events or situations persisting for at least 6 months. The answer is yes, because she has worry about everything, pretty much, all kinds of things, including situations and events. So we're going to do yes. And there we go. Generalized anxiety disorder is our final diagnosis for the anxiety syndrome, anyway. But now we can move on to one of the other syndromes, because she does have a few others. And we'll use, let's go with, how about let's go with the irritable mood, maybe. That's a good one to use as an example. So let's get back to our DSM-5 differential diagnosis app here then. And let's look at mood. Do some screen share. Down to irritable mood. And we're going to hit start. Is it due to the physiological effects of a substance, including medication? Again, we're going to say no. The irritability goes back to her adolescence. She was not taking using any substances or medication at the time. Even when she stopped using substances later on, she continues to have problems with irritability. So we're going to say no, it's not. Is it due to the physiological effects of a general medical condition? Again, for reasons stated earlier, no. Is the criteria met for a manic episode, i.e., has there been at least 1 week of irritable mood accompanied by increased activity or energy and at least 4 other characteristic symptoms sufficiently severe to cause marked impairment? The answer is no, because her irritability generally only lasts for maybe hours at the most. We're not going to see that it goes on for at least a week. And it's certainly not accompanied by other symptoms of mania. This is one of the areas, this is an area where I often see misdiagnosis. People will see a client who has a lot of wide swinging mood swings. They might think bipolar because they think mood swings bipolar. But with bipolar disorders, with manic episodes, you're going to have these persistent symptoms lasting for several days, at least a week for mania, or with sufficient severity to require hospitalization, and for hypomania, at least 4 days. So we're going to say no. Is the criteria met for a hypomanic episode? Well, as I just mentioned a moment ago, no, because we don't have this irritability persisting for at least solid 4 days without any relief, and certainly not accompanied by other symptoms of mania or hypomania. So we'll say no. Is there a present or past manic episode? No, there is not. Is there a present or past hypomanic episode and at least 1 major depressive episode? Well, again, we've already ruled out hypomania, so no, there's not. Has there been at least 2 years of hypomanic symptoms and periods of depressed mood? No, we don't have hypomanic symptoms going on for at least 2 years. Is it occurring only in association with periods of depressed mood? No, not necessarily. Sometimes she has days where she's feeling perfectly fine, and then she starts feeling irritable for maybe a couple hours, a strong, significant irritability, and then she shifts back to feeling maybe okay, or feeling depressed, or feeling anxious for that matter, but not necessarily always depressed, so we're going to say no. Is it occurring in the context of severe temper outbursts that are grossly out of proportion to the situation with persistent anger and irritability between outbursts? No, that is not the case for her. These are very short episodes of irritability. Is it occurring in association with a pattern of argumentativeness, defiance, and vindictiveness? No, this is kind of probably an oppositional defiant disorder rule out or something along those lines. But no, that is not the case for her. Sometimes irritability is actually very much attached to anxiety in her case, so we're going to click no. Occurring as part of a persistent and pervasive pattern of instability of interpersonal relationships, self-image and affects, and marked impulsivity beginning by early adulthood. The answer for this one's going to be yes. It's going to be yes because ever since adolescence, she's acknowledged unstable interpersonal relationships, a poor sense of self, and a difficulty regulating her emotions or moods. And there are certainly periods of marked impulsivity, and it did start by early adulthood. So we're going to click yes. And here we go. We've arrived at a diagnosis of borderline personality disorder. So hopefully this will give you a little bit of an example of how to use the DSM-5 Handbook of Differential Diagnosis app to help you to arrive at a clear diagnosis.
Okay, so I want to say a few things about Bernadette's case. Now, by the way, we wouldn't worry about step 5, differentiating adjustment disorders from OS and US categories, because we never suspected adjustment disorder, or by this point we kind of ruled that out. And for the 6th step, which is, are the symptoms clinically significant? Yeah. She's been hospitalized. She had a suicide attempt. She's had failed relationships, difficulty maintaining employment. So, of course. Now, I also used other tools with this client besides the clinical interview. I administered the personality assessment inventory, which yielded an elevation in the negative impression management score, as well as anxiety, anxiety-related disorders, depression, paranoia, borderline, suicide, stress, and non-support scales, with diagnostic considerations of MDD, PTSD, rule-outs for panic disorder, agoraphobia, generalized anxiety disorder, specific phobia, bipolar II disorder, and borderline PD. I gave her the PID-5, which is a free measure, and both the client and the informant versions, because I gave her husband and informant version, yielded elevations in personality trait facets of anhedonia, anxiousness, depressivity, etc., and were suggestive of possible borderline personality disorder and avoidant personality disorder diagnoses. And I got records from the hospital, and I interviewed her husband. Now, there are some free tools that I can tell you about, and some that are not so free, about some of those tests and measures. But before we do that, this is what ended up being my list of diagnoses for Bernadette after a very thorough evaluation. Notice it's different than what the hospital diagnosed her with. Notice all these Z codes. These are not disorders. These are diagnoses in the final chapter of section 2 of the DSM-5 TR, called Other Conditions That May Be a Focus of Clinical Attention. And that includes all of the circumstances and stressors that may be impacting the clinical picture that might be good to address in the course of therapy, or that might be good to refer her to other sources to address if you're not going to address it. Now, not to get on too much of a tangent here, but I was trained to diagnose disorders conservatively and diagnose these Z codes liberally. Because here we're saying these are not disorders. This is a succinct way of summarizing the entire biopsychosocial assessment. All of the problems that the assessment discovered that she's concerned about are all listed here in a small list. These are the disorders up here. Now, the hospital diagnosed her with bipolar II disorder. Why did they do that? Because she told them that she has wide mood swings. But guess who else has mood swings? People with borderline personality disorder. What's the difference between the two? Well, if you have bipolar II disorder, then you have to have had at least one hypomanic episode, which would mean that those periods of irritability or mania would have to have persisted for at least 4 days and be a deviation from the person's normal self that was sufficient to cause significant impairment or distress. In her case, those irritable episodes tend to last for hours. They don't last for 4 solid days or longer. This is another case where, in my opinion, she was misdiagnosed. And so they primarily focused on medication, a mood stabilizer for bipolar disorder. And they thought supportive counseling would be good to make sure she's taking her meds and help her out with when she gets a little bit more depressed and stuff. But no, this was a client who I ended up referring for a full DBT program for the borderline personality disorder. She did a 6-month DBT program, made dramatic progress, shifted to outpatient therapy, and has done very, very well. And the turning point for her was getting an appropriate diagnosis and then learning about treatment options that no one had discussed before, framing the symptoms and the disorder, and the treatment and how the two match each other well. This isn't Borderline personality disorder is not a condition for which you just take meds and get a little supportive counseling. That's not normally the way that it's effectively treated, at least not rapid, not, um, I mean, there are isolated cases where people meet the criteria for borderline PD, um, and then they stop meeting the full criteria later in life, but they still have traits, even sometimes without therapy. But we don't want her to have to wait decades to have that experience. We want her to get relief quickly and to get the care that she needs. So I used the decision trees as one of my resources, but I still went through the 6-step differential diagnosis process and used a variety of data sources to do so. Now, MBFE has a training called Fun with Z Codes. If you want to learn more about those Z codes I was telling you about, you can actually watch that training for free on YouTube. Or if you want to get a CE certificate, then there's a way to register and pay for it. And all this is in your slides, so you can look at this later. There's a how to use free online assessment measures for mental health evaluations, a bunch of free screening tools that you can use to more rapidly arrive at a diagnosis. And there's a free video on my YouTube channel about that. I think it's 2 hours long. Or if you want to get CEs for it, there's a way to register and get CEs. There's one on personality disorders. Testing for forensic populations is an expensive training that's a 40-hour workshop that teaches you how to administer and interpret more advanced psychological tests and get level C qualified for psych tests. Um, it it's didactic and experiential because you're actually given assignments and you're coached until you can pass them with 100% accuracy to show that you can accurately score and interpret tests. So by the time you get done, you've got some good supervised experience under your belt to go with. It costs $1,500 though. Well worth its weight in gold. I paid for it back in 2016 when I took it, but it's not an inexpensive one. And just to be on the safe side, I could go to bipolar disorder for this client and I could look at the differential diagnosis section of the DSM. And sure enough, it says personality disorders such as borderline personality disorder may have substantial symptomatic overlap with bipolar disorders, since mood lability and impulsivity are common in both conditions. Symptoms must present a distinct episode and the noticeable increase over baseline required for the diagnosis of bipolar disorder. A diagnosis of personality disorder should not be made during an untreated mood episode. Under the differential diagnosis for depressive and bipolar disorders section in borderline personality disorder, it talks about how really kind of the same thing. Look at onset and how lengthy is the course and so on. Now, we have 5 minutes left. I have a bunch of other cases that you can read on your own. One case where I concluded that the hospital that had diagnosed a client with bipolar disorder really had bipolar disorder due to substance use. What was really going on is they had an addiction to methamphetamine, and that was producing the manic symptoms, which essentially disappeared when they got into recovery. So I don't think they really had bipolar disorder. They were getting the wrong kind of treatment. And I give some other examples in here as well, and lots of tools that you can look at for some different measures. But we only have 4 minutes left. So I figure this would be a good time to see if you have any questions that we haven't gotten to answer yet. First question in the chat box. I'm wondering why you did not explore the possibility of PTSD based on the Z code underlying information. Neglect and past abuse issues may, in fact, be potential indicators of PTSD. That's true, they can be, but to qualify for PTSD diagnosis, you have to have experienced a traumatic event that was life-threatening or that involved sexual assault or witnessed somebody else with those kinds of scenarios, and she did not have that in her history. So yeah, she did have abuse and she does have trauma, but she does not have PTSD. So I could already rule that one out. All right, I don't see any other questions. So was this helpful to you in terms of learning some strategies and tools that you might have that could reduce the likelihood of a misdiagnosis, which is a medical error, which in turn could lead to somebody not getting the right treatment or not getting the right relief, which hypothetically in turn could lead to them getting worse or not getting better. And some ways that you could kind of beef up your differential diagnosis process. Was it a good starting point for you at least? It's been an absolute pleasure. I hope you all enjoy the rest of your Friday and have a wonderful and restorative weekend. And I'll see you next time.
Thank you.